Good day, everyone, and welcome to the United Nations Academic Impact Global Regenerative Medicine and Wound Repair Workshop. My topic for today is diabetic foot ulcer management overview, and I'll talk about its epidemiology, etiology, pathophysiology, and prognosis. I'm Dr. Pauline Jean Rosel Ubial, a former Minister of Health of the Philippines and now with the Philippine Red Cross and the UP College of Public Health. I had a training on uh, wound care and regenerative medicine in September 2019 in Beijing, China. And the epidemiology of diabetic foot ulcer begins as diabetes, one of the most common non-communicable diseases nowadays in China, in the Philippines, and in the world, and many developing and newly industrialized countries. The epidemic is growing at a dizzy rate. The main problem for diabetes are related to chronic complications of the disease. Among the complications of diabetes is diabetic foot ulcer and is gaining new importance because of it implies for diabetes the highest number of hospital admissions and considerable cost. In fact, about 15% of diabetics will experience this condition in their lifetime. The greatest risk for patients is amputation. And according to several noted studies, 20 to 50% of diabetic patients receive immediate amputation at the time of the first visit due to uncontrolled infection. Overall, it is estimated that 50 to 70% of all lower limb amputations are due to diabetes. And diabetes is the leading cause of non-traumatic amputation of the lower limb, especially in Western countries, with the risk in diabetic patients 15 times higher than non-diabetics. And the etiology is because of high blood sugar levels. Now, in diabetic patients, the sugar levels are uncontrolled. So it is a metabolic disease. And elevated blood sugar levels narrow the body's blood vessels and stiffens the artery, resulting to atherosclerosis. And this restricts the delivery of blood and oxygen to major tissues of the body. This in turn prevents the body's natural healing process to effectively work. So the poor circulation is actually the risk factor to develop peripheral arterial disease, PAD, which restricts blood flow to the feet and the legs. And PAD is especially difficult for those with chronic wounds like diabetic foot ulcers. This is because it can seriously interfere with the body's ability to heal itself. And if untreated, PAD can result in amputation of the affected limb, which is often the case in my country, the Philippines. Nerve damage is also occurring in diabetes. Uncontrolled blood sugar levels can result in nerve damage, and diabetic neuropathies are a form of nerve disease that cause loss of sensation, including the ability to feel pain. For those who have nerve damage, a small cut, a blister, or for wrongly fitted shoes or surgical wound can result in an infection and result in an ulcer. The tissues with your immune system. Diabetes also has an negative effect on our immune system, which inhibits the body's ability to clear away dead and damaged tissues. It also prevents the body from building new skin cells once a wound or injury has occurred. It can negatively affect the body's ability to send white blood cells to fight bacteria in an infected diabetic foot ulcer. So, when infected, the patient is susceptible to infection. And as they have weaker immune system, in diabetics, it is common for a wound to develop an infection like non-healing or infected diabetic foot ulcer. The pathophysiology is that the lesions involving the skin break usually results from combination of diabetic neuropathy, ischemia or poor blood flow, deformity, and the weakened immune system can actually worsen the infection, whereby the patient will develop necrosis, gangrene, and then ulceration, and on the plantar and side surfaces, especially of the big toe. So, diabetic foot ulcer present as asymptomatic until microorganisms enter and multiply on the wound, creating a foot infection. They can be classified into three grades based on the degree of ulceration and type of infection. Treatment depends on ulcer grading, ranging from prescription antibiotics and wound care up to amputation. So the prognosis is methods, multi-center prospective observational study reviewed participants' data at 12 months after culture of diabetic foot ulcer requiring antibiotic therapy. For patients' notes, we obtain information on the incidence of wound healing, ulcer recurrence, lower and extremity amputation, lower extremity revascularization, and death. We estimated the cumulative incidence of healing at 6 to 12 months. So it takes a longer time to actually heal a diabetic foot ulcer compared to any other wound in the body. Adjusted for lower extremity amputation and death using a competing risk analysis and exploring the relationship between baseline factors and healing incidence. So here's the prognosis. In the first year after culture of the index ulcer, 45 out of 299 participants, or 14.1%, died. The ulcer had healed in 136 participants, or 45.5%, but recurred in 13, so recurrence was 9.6%. An ipsilateral lower extremity amputation was recorded in 52, or 17.4%, and revascularization surgery was done in 18 participants, or 6%. Participants with an ulcer present for less than 2 months had a lower incidence of healing, hazard ratio of 0.55, with confidence interval of 95%. Okay, as did those with a PEDIS, perfusion extent deep infection sensation, perfusion grade of less than more than 2 or more, hazard ratio of 0.37 with a confidence interval of 95. Participants with a single ulcer on their index foot had a higher incidence of healing than those with multiple ulcers. Hazard ratio is 1.90 with confidence interval of 95%. So the conclusion in this study is clinical outcomes at 12 months for people with an infected diabetic foot ulcer are generally poor. Our data confirm the adverse prognostic effect of limb ischemia, longer ulcer duration, and presence of multiple ulcers as aggravating factors. If you are fortunate enough to detect diabetes, the best way to prevent diabetic foot ulcers is actually to detect and to control diabetes. Do everything you can to prevent it from remaining until your old age. Now, I will also tell you about the things that we learned in my training in wound care in Beijing. In that training, we were using the MEBO, or moist exposed burn ointment. And this is a Chinese medicine that is very effective for burn patients as well as for diabetic ulcers and other wounds. Okay, so the main method or how MEBO works is it discharges the liquefied necrosis of skin without any further damage. So it removes the necrotic tissue without actually going to the minor operating room, because the patients are very comfortable and they do not feel pain. And it has regenerative medicine capacity. It activates the human regenerative instinct and creates a favorable environment for regenerative and realizes skin regeneration and healing in situ. So those are the two mechanisms of action. So in this center, the MEBO is applied. It's cleaned out every day and applied a fresh coat of MEBO on the affected wound every day. And superiority results are evident when MEBO is applied at the earliest possible time, meaning within 12 hours of the injury. Avoid the use of water. So there's no like sterile water or disinfectant that is used. Only the MEBO ointment. And avoid causing pain, bleeding, or any secondary injuries when cleaning. So we don't use forceps. We just wear rubber gloves and then use cotton or the gauze where you have the old MEBO ointment being used to lubricate and remove the dead tissue. Then after doing that, you apply the new MEBO ointment on the wound. and this is done every day. Timely remove the liquefied necrotic tissue and exudates and mebo before smearing the new coating of mebo. So in my stay at the Beijing Burn Unit and Wound Care, we saw this case number 1 with diabetic foot ulcer. So you can see there are multiple ulcers on the plantar and the lateral sides of the left foot. Okay. So this was treated for 50 days, and you can see the healing and the regeneration at the right side of the slide. Then again, we have case number 2, and this is an ulcer in between the big toe and the smaller toes. Okay, so as you can see, this particular case was treated for 60 days, and look at how the skin is now growing over the exposed wound. And this is case number 3, therapeutic mechanism in the treatment of diabetic ulcers with mebo. So you can see on the leftmost slide, the necrotic small toe, okay, and it was removed. There was debridement, and after 30 days, that is the middle slide, and after 60 days, there you have the skin growing over the wound and the amputated little toe. So as you can see, there is good wound healing, and there's no need to do lower limb or below the knee amputation. So in this center where we visited in Beijing, there was hardly any amputation, and they didn't do skin grafting. It was just the wound care using mebo, moist exposed burn ointment. So I'm very happy to share with you this new advancement in diabetic foot ulcers. Thank you very much, and have a nice day and a good conference.